Yeah, so let's talk about cataract surgery.
Let's do it. This is a wonderful video of a recent patient doing cataract surgery. First portion here that you're seeing with that instrument is measuring or indicating the size for the capsular rhexis.
So think of it like a stencil, just to make sure I have the right size and the right shape. I tend to make 2 small incisions for better access. Should the patient move their eyes, this is under topical anesthesia. I still have another port should one go underneath the lid.
And making the larger side incision where the actual lens is going to be placed in, and most of the work is going to be done from that area. This is the capsular rhexis just starting, and it's going to be a manual capsular rhexis. And what's the size that you're targeting for that capsular rhexis?
Around 5 to 5.5 millimeters. There should be about 100% overlap over the optic. The optic of the IOL is about 6 millimeters. A normal lens is about 9 millimeters.
That is just incredibly thin tissue, it looks like, just peeling off. I've heard the analogy before, like the skin of a grape that you're peeling off of the actual cataract itself. Is that a fair analogy?
Or tomato. It's like something that's blanched, easy to peel off. And yes, the challenge here is to keep it round and the same size. That's why some surgeons prefer using the laser, although again, no studies for now have been shown that the laser provides any benefit in the final outcome to a patient.
And we saw a quick view of viscoelastic also. Is that separating the rest of the capsule from the cataract beneath, or is that just cushioning the anterior chamber?
So the little wave that you saw is hydrodissection, where fluid passes around to separate from the nucleus from the lens, from the capsule. And then this is a prechop where no phaco energy is used. Phaco energy is the energy that we think damages the cornea most. This is a manual technique to break up the lens into smaller pieces. Again, similar to what some surgeons use a laser for, but again, no reusable, no extra cost to the patient at all, but tends to decrease the amount of trauma applied to the different tissues.
And just to, I think that's an important point, the phaco is concerned for corneal damage, specifically endothelial damage, causing problems for those pump cells.
Yes, so that little probe, the metal tip, vibrates very quickly and breaks up, emulsifies the lens. On the side here, there's 2 little openings that bring flow into the eye here and here. So fluid goes in here. As you can tell, all those pieces go to the tip, and then that is replaced with liquid out of the side of the little phaco probe. This is an irrigation aspiration handpiece. The top here is a port that aspirates, and again, on the side, fluid comes out.
And we're just making quick work of that cataract, pulling it out. Is this mostly nuclear or cortical, or a combination of both components at this point?
This is not just cortical. The nuclear material looks a little more yellow. There's a little piece of nuclear that's remaining. And because it's not easily aspirated, I wanted to use a second instrument to kind of break it up manually. But as you can see, it was removed with just vacuum power.
And this is now, of course, cleaning out the new housing, or really not a new housing, but where the bag or the capsule is. That needs to be perfectly clean and pristine, because that's going to be where the new lens is implanted, providing the patient with excellent vision. So that is being polished and cleaned off as nicely as possible.
Mm-hmm. And so this is now the posterior capsule, which is even thinner than the anterior capsule. So you'll see some wrinkling, and this port is very nice and gentle because it's made out of plastic, so less likely to tear or distort or damage the capsule. This is a curette, which again polishes as many of the epithelial cells as we can to decrease the chance of that capsule shrinking later on. It's called capsular phimosis.
Does that also have any help with future PCO development at all, or not so much?
So I've seen different studies based on this. It seems like decreasing the amount here decreases the amount of fibrosis in the front, but may increase the rate of PCO, as in it happens a little bit sooner. PCO is just an opacification of the posterior bag. This is a one piece going into the bag. One piece again because the haptics are made of the same material as the optic. Second instrument rotating in place, and you'll see that these unfold pretty slowly. This is a hydrophobic acrylic. At some point we'll talk about lens material as well, just to see the differences and how they developed over time.
For now, any particular reason why you might choose at least a one piece? Can we comment on that right now?
One piece goes through a smaller opening. This is a 2.4 millimeter incision. The one piece folds up more tightly and smaller than a 3-piece, which we'll probably see in another video. Those require a larger opening and more manipulation. Now the wound is hydrated, and then antibiotic is injected by me in the front part of the eye as well to decrease the chance of an infection. And just centering the lens one more time, and you can see again there's a nice overlap of the capsular rhexis over the IOL.
And final stage here is the actual subconjunctival injection of the steroid, just to provide that anti-inflammatory effect after surgery, and that's going to stay in the eye for a couple months, but it gradually gets smaller and smaller in size.
And that swelling will be gone by the next day. The initial swelling is just some anesthesia, and then that white stuff that you saw injected is the actual steroid.